We're back. And today we're talking about how many radiation treatments you need for cancer. Ideally, you would need just one treatment for any cancer in any setting, but that's just not the case. And why is that so? There are a few problems if you give radiation therapy all in a single dose. First, the normal cells don't get to repair. So when you're giving radiation therapy, you're damaging both the cancer cells plus normal cells in your body. And the cancer cells have problems repairing DNA damage, and we're trying to exploit that by giving multiple treatments in a successive fashion from one day to another. Normal cells are able to repair that damage better than cancer cells in general. And so, if we're able to give multiple doses or fractionate the radiation therapy, we can exploit that advantage. What this means is that you can potentially have worse short term side effects, and the short term side effects with a large dose of radiation all at once is usually something inflammatory. So, skin redness, itchiness, peeling, and that can be in any part of the body, but just short term inflammation. In the long term, you can potentially have worse side effects as well. And the main side effect is fibrosis. And the way I explain this usually to patients is that it is scar tissue formation or it is aging the body. It's basically like adding 10 years or 20 years of life onto the tissue that has been radiated. So it's not going to look like the other skin that is on the other part of the body. The second problem, if we give a big radiation dose all at once, is not taking advantage of oxygen. So we need oxygen to cause the DNA damage that will eventually help kill the cancer cells. And so if we give radiation all in one dose, we use up all the oxygen, there's not any more left, and theoretically the radiation is just not going to cause as much damage as it would if we had waited for a little bit of time, let the oxygen rebuild in the cancer cell, and then deliver another dose. Number three, some cancer cells are not actively dividing and are in a protected state if we're using just a single treatment. So what this means is that your cancer cells that are in the body are trying to replicate, but they're not all replicating at the same time. And some of them are replicating and they're in a relatively vulnerable state. And during that state, they are susceptible to radiation damage versus in their non-replicating state, they basically have everything packed up and they're resistant to radiation damage. So the analogy I sometimes give to patients is that it's basically like if you're planning an attack with the army on the enemy, you want the enemy to be totally unprepared. And in this case, the enemy is trying to make more copies of themselves. They're writing notes. That's like the DNA. They're not prepared, and they don't have their defenses up. And so we want to try to catch them in this state with our radiation. And so if we give multiple doses, we're able to catch more and more of those dividing cells. Number four, the living cancer cells after a single treatment may start to repopulate. So ideally, we catch those replicating cells on the next treatment, and we do it the next time and the next time. And next, our accuracy has to be perfect. So if we are just giving one radiation dose with this really big dose, the accuracy really matters. So we can't be off by millimeters because we're going to start to kill. So given these issues, radiation oncologists have historically tried to give a small dose of radiation every day for many weeks. And this gets into what we call fractionation. You're getting a fraction of the radiation dose a day. Let's discuss some of the commonly used terms for fractionation. Historically, we have tried to use something called conventional fractionation, or the other term for this is long course radiation therapy. So I'm giving an example here with prostate cancer, where the dose is 80 gray in 40 fractions. So that means you're getting 2 gray per day. The analogy that I sometimes use is that the radiation is kind of like building a brick wall, and we're laying down one small brick every day until the whole wall is built. However, we can also use larger bricks to get the wall done faster. And so this gets into the idea of hypofractionation, or short course radiation therapy. Hypo means less, so just less or fewer fractions than you would receive normally. So in this case, for prostate cancer, we're treating to 60 gray in 20 fractions. And so you're getting 3 gray per day. So the size of each brick is larger, but the overall size of the wall is the same. And there's a mathematical formula that goes into this. It's not just a simple multiplication problem or addition problem. So the math won't work out if you just try to multiply them. But these two fractionation regimens are relatively similar, at least for prostate cancer. Another option is to do just 5 treatments. And so for prostate cancer, it's somewhere between 35 to 40 gray. And in this case, it's 7.25 gray per day times 5 treatments or 5 fractions. And in this case, it's every other day that you're getting the treatment. And then finally, and this is not necessarily for prostate cancer, but you can actually just get one radiation dose, just that this is less commonly used. Maybe this is used for a metastasis in the brain, where you're getting something like 20 gray, or maybe there is a metastasis that went to a bone and is causing pain, and you're getting something like 8 gray in a single dose. And this is very much dependent on the cancer and the area that is being treated. And typically, this is not used for prostate cancer in the intact setting. Okay, there are subclassifications. So if you're getting 5 fractions, there are some cases, depending on the criteria that are met, where you're actually getting something called stereotactic body radiation therapy, or SBRT. That is 5 fractions or less, with high accuracy, high precision, sharp dose fall off, and definitions that we're going to discuss in a different talk. And specifically, this is outside of the brain. So basically, below the brain, although you can technically have SBRT to the head and neck area, and there are many men who are treated with SBRT for prostate cancer. The other term for this is ultra hypofractionation, so like very short course radiation therapy. If you get just one fraction and you get it to the brain, you're getting something called stereotactic radiosurgery, or SRS. What if you get multiple fractions to the brain? Well, you get something called fractionated stereotactic radiation therapy, or FSRT. And so these terms are sometimes used interchangeably. They're technically different things, and they really depend on the fractionation given, the location of the body, and also where you are in the world, because the SBRT is technically a US term, and outside of the US it is not used. All of these different fractionations can be delivered with something called 3D conformal radiation therapy or intensity modulated radiation therapy, IMRT. We will discuss that in a separate presentation. The goal of treatment determines the fractionation. And so the first question that we ask is, are we trying to improve the length of life, or are we trying to cure the disease? And if that's not the case, maybe we're just trying to improve the quality of life. And so what this means is that if we're trying to go for a quote-unquote cure, we are treating with definitive intent. We want to improve the length or the quantity of life. And of course, we also focus on quality of life. We don't want to make your quality of life worse, but we try to balance those two things. And this is historically used for cancer that is not metastatic, that has not spread, although this is changing, and I'll tell you why in a little bit. The other option is for palliation. Palliation means to make symptoms better, and that means to improve quality of life. So if you have something that's causing pain, we're going to make the pain better. And historically, this is because of metastasis, cancer that went somewhere else in the body, and causing pain, obstruction, bleeding, etc. In the definitive intent state, there's something called, there are different settings. So you can have neoadjuvant, so that's before a surgery. You can have adjuvant and salvage, so that's like after a surgery, or you can have the definitive setting, so meaning that we're not using surgery at all. We're just going to use radiation therapy for your cancer. And this is oftentimes used for lung cancer, for prostate cancer, skin cancer, etc. Historically, when you combine radiation therapy with surgery, these have been quote unquote long course. So oftentimes patients are coming in for 5+ weeks of treatment. This is sometimes, this is changing a little bit, and this is not always the case. Sometimes it is short course. I'll show you a little bit of the data in a little bit. But I would say for the majority of patients, it's probably going to be long course. In the definitive state, and so specifically for prostate cancer and smaller lung cancers, there is a trend in the field to go from longer courses to shorter courses and fewer treatments. This is very much determined by clinical trials, and the clinical trials are testing the cancer quote unquote cure rate or the control rate and the side effects or the toxicity. Finally, in the palliative setting, historically, these are short course treatments. So for patients who have metastatic cancer, we ideally want to get them back to their family ASAP. We want to keep them out of the hospital, and we want to improve their quality of life. And so we want to make the treatment as short as possible. If you look across all cancers that are treated in radiation oncology departments, and you look at the number of patients who are treated, you break them up into these settings, the neoadjuvant setting, the adjuvant, and the definitive setting, you will get a plot like this. So this is actually some of our research that we did using the National Cancer Database, and this is for patients who are treated in the definitive, with definitive intent. So we're trying to cure the cancer. And you can see that the highest bar is actually breast cancer in the adjuvant setting. So that means that these are post-operative patients, and they're receiving radiation therapy. After that, it is actually the definitive setting. So it is prostate cancer, non-small cell lung cancer, head and neck cancer, and then small cell lung cancer. And so these are patients who are not getting surgery, they're just getting radiation therapy alone. And then you can see all the other cancers that are treated with radiation therapy. And we do treat basically every cancer from head to toe. It's just that their volume is lower than the others. So what are the fractionation trends for many of these cancers? I'm going to list the fractionation trends that are used in the US, and we would have to pull up studies for each one of these cancers to get the trends. And I'll show you just some of the data, at least for prostate cancer, in a little bit. But you can see that for rectal cancer, it can be conventional or hypofractionation. For esophageal cancer, it's mostly conventional fractionation. Sarcomas, mostly conventional fractionation. Breast cancer used to be conventional, but it's moving to be hypofractionation. And oftentimes we actually do it in just 5 treatments. And there are many other cancers that you see listed here where the fractionation or the number of treatments is actually shifting. It's becoming fewer and fewer treatments over time. And so prostate cancer is one of those examples. So what are some of the recommended fractionation options for prostate cancer? So this is with radiation therapy alone, and this is not with surgery. So you can see these are our guidelines, our national guidelines that we follow, and we can use moderate hypofractionation, conventional, and then SBRT or ultra hypofractionation. And the guidelines give us some of the recommended doses and also some of the recommended risk groups who can receive this. Now, you should discuss with your physician why you might be getting one fractionation regimen versus another. This does not mean that everyone should be treated with X fractionation regimen, and there are some guidelines and some caveats that would recommend one treatment versus another, and we'll discuss those, at least for prostate cancer, in a separate video. So here, I want to show you some of the trends for the use of conventionally fractionated, moderately hypofractionated, and ultra hypofractionated radiation therapy for prostate cancer. And this is among different risk groups. This is also research from our group, and it is looking from the 2000s up to 2020. And you can see that conventional fractionation kind of used to be the standard of care. No one used to do SBRT. And now SBRT is slowly picking up. And actually, in our practice, a plurality, if not a majority of patients are receiving SBRT. So that is radiation therapy fractionation in a nutshell. I hope you found this video interesting. And if you have any questions, please reach out to me at any time. I hope you all have a good day.